Here in the new year. Thanks so much for joining us. We have a great program today. I have a couple of things I was going to go over before I turn it over to Tara. I wanted to let everybody know that we have scheduled our summit for this year. It's going to be on May 22nd at Seawalls, and our topic is going to be From Smoke to Hope, Exploring Cessation Strategies Across the Generations. So we're really excited about that, and we'll be setting up registration in the coming months. And then also I wanted to announce that we're having a high school and middle school youth summits on April 29th and 30th, and that will be Escape the Haze, Facts Over Fumes. And if you have any schools that might want to attend, you can reach out to Tara and she will send you information on where it's going to be and how to register. And then last but not least, I want to introduce our new community engagement coordinator that we just hired, Vanessa Logan. Vanessa, you want to wave at everybody and say hello?
Absolutely. Good morning. Hello, everyone. Happy Friday or Friday. Do we still say that? Friday?
Yeah.
Okay. I was making certain that I wasn't out of bounds with the teens or the youth of what we say. Yeah, okay, Friday. Hello, everyone. Happy to be a part of this amazing team. This has certainly been some great opportunity to connect and help to eliminate what we are geared towards. A great conversation. There's a lot to learn, and I'm very excited and so happy to meet everyone.
Thank you, Vanessa. So now I'm gonna turn it over to Tara because I know we want to get the meeting started. Everybody wants to hear Reston, and I think Beth's going to give an update too. So good morning and welcome.
Yeah, thanks everyone. Thanks for joining us this chilly Friday. Hopefully wherever you are, you're warm and toasty and comfortable. We're excited to have Reston here this morning as our guest speaker. Before he starts, we're going to hand it over to Beth Johnson from ACS CAN, who's going to give us a legislative update, things to expect, things to work on this coming legislative season. So Beth, it's all yours.
All right. Well, good morning. I am also very excited to hear Reston. Reston is you'll share about him later, but Reston's a dear friend and I'm so excited, and he's just such a brilliant mind. We're very thankful to have him here in South Carolina. So the General Assembly, they met last week. They kicked off session January the 14th, and right out of the gate started setting up the agenda for what the year is going to look like. This week, actually, they all met in perfunctory scheduling, which is basically they did meet. They had a couple of meetings, but they're moving right along. And so I wanted just to address a few things that the national partners are looking at and are hoping to really work on this year. And one is kind of the continuation of what we did last year, which is increased tobacco prevention and control funding. So thankfully, we were able to ask for and receive $1 million in state funding last year that went to Smoke Free SC for some great projects and work that the team has planned. And we are going to go back to the General Assembly this year and ask for additional funding. The funding we received last year was a one-time, it was called a proviso, it was a one-time fund. So we are going to go back and we're going to ask for additional funding. South Carolina is still receiving money from the Juul settlement. And so our argument is that money that South Carolina is receiving from the Juul settlement should go to tobacco prevention and control. The other bill that kind of popped up end of last week is a vape registry bill. And it is an industry-driven bill. It's one that we saw last year. It is being introduced, has been introduced in the House by leaders of the House. The House majority and minority caucuses are co-sponsors of this bill. It would essentially require retailers to register with the Attorney General's office if they are selling electronic cigarettes. And the bill specifically says vape products. So this is the bill that we are seeing around the state. I believe there are 8 other bills that have popped up in exactly the same bill. From ACS CAN's perspective, we will monitor this bill for any additional bad language that could be added. They could always add preemption to something. So we'll be monitoring, we'll be taking a look at, but we will likely not comment. We don't support it. We feel like it's certainly a bill that will not do anything to help prevention and control efforts in the state. So those are two big things right now. I'm sure there'll be some other things that pop up, but always happy to have this group engage with us. And I will put a plug in for our day at the State House, which is going to be February the 26th in Columbia at the State House, and everyone is invited. I'd love to have you join us.
Beth, we can put that in our February newsletter as well.
Good. Thank you.
Of course.
Thank you.
All right. Well, thank you, Beth, for that information.
Yeah.
Dr. Keeley, go ahead.
Yeah, Beth, what's the team talking about these days in terms of taxation of
Oh, yeah.
vapes?
Not much, Dr. Keeley. You know, we would like to see legislation that would tax all products at parity, and so we could bring the electronic cigarettes and other products up to what the tax is currently on combustibles. However, the legislature would not fly in South Carolina. Like, it's not going to run. We couldn't get it off the ground right now. However, you know, there could be a time for that in the future if we see the state budget diminish some. But as long as we continue to have a surplus of the state budget and the General Assembly wanting to cut taxes across the board, it would be a non-starter conversation.
All right.
Unfortunately.
Yeah. I don't know what the revenue generating estimates might be. Do you have anything that anybody's looked at?
We do, yes. Dr. Frank Chalupa and our partners with Tobacco Free Kids and ACS we can pull those numbers. I haven't pulled them from South Carolina because it's not a campaign that we're actively engaged in, but we can pull those numbers and just, you know, for our own kind of knowledge, we have what we would estimate the tax revenue to be. Yeah.
Yes.
Happy to do that.
Thank you.
Yeah, sure.
Any other questions for Beth? All right, I'll pass it over to Reston. I'll let him introduce himself and get started with his presentation.
All righty, let me go ahead and share my screen here. So, un momento. All right, well, good morning. It's a pleasure to see many familiar faces and some not so familiar. So if we haven't met before, my name is Reston Hartsell, and I'm an epidemiology doctoral candidate at the University of South Carolina Arnold School of Public Health. Prior to working on my doctorate, I worked at the South Carolina Department of Alcohol and Other Drug Abuse Services as the SINAR Tobacco Prevention Coordinator for over 2 years. And this opportunity exposed me to a wide range of tobacco prevention and control topics, as well as amazing people. And because of my role at DEODIS, I became involved with Smoke Free SC, what was formerly the South Carolina Tobacco Free Collaborative. And I had the privilege of serving on Smoke Free SC's board of directors with Beth and others, Dr. Keeley, between 2018 and 2022. And so with that being said, I'm excited to join you for today's roundtable discussion. And so over the past 3 years, Dr. Anthony Alberg, my mentor at the University of South Carolina's Arnold School of Public Health's Epidemiology and Biology Department, and I have collaborated with the Department of Public Health's Tobacco Prevention and Control section, especially Helen, Sharon, Dan Kilpatrick. I want to give a shout out to him especially too, Kim and many others. And so we collaborated with them to generate novel estimates of secondhand smoke-caused mortality for South Carolina. In my presentation this morning, estimation of the population burden of mortality caused by secondhand smoke in South Carolina adults, we'll review our findings from 2 papers we wrote and we're trying to publish. Let's go ahead and get started. So as you all are already aware of, active smoking is the leading cause of preventable deaths in the United States, but we must also address secondhand smoke, which is a major public health threat that's completely preventable. Secondhand smoke contains over 7,000 chemicals, including 69 known carcinogens, and there's no safe level of exposure. And so when I refer to secondhand smoke exposure, this is coming from burning combustible cigarettes. And so this exposure happens in homes, in vehicles, workplaces, public spaces, impacting both smokers and non-smokers. And so we know from mountains of evidence and synthesized evidence from multiple Surgeon General reports that secondhand smoke exposure has been judged to be a causal source of lung cancer in the 1986 Surgeon General report. It's a cause of coronary heart disease in the 2006 Surgeon General report, and a cause of cerebrovascular disease or stroke in the 2014 Surgeon General report. And so secondhand smoke has caused over 2.5 million non-smokers to lose their lives in the United States since 1964. And most recently in the 2024 Surgeon General report, these estimates have been updated to where 19,000 individuals die from exposure to secondhand smoke each year from coronary heart disease and lung cancer. And these are conservative estimates because they don't include stroke deaths. As the harmful effects of secondhand smoke exposure became known, a major public health triumph in the United States has been the decline in the prevalence of secondhand smoke exposure, as the prevalence of non-smoking Americans who were 20 years or older exposed to secondhand smoke has declined from 87% in 1988 to 1991 to roughly 21% in 2015 to 2018. So despite smoke-free policies, there are still gaps in implementation, leaving vulnerable populations unprotected. Secondhand smoke disproportionately affects youth compared to adults, Black individuals in low-income households, and adults with lower education levels. While secondhand smoke exposure has decreased over time, hundreds of thousands of South Carolinians remain at risk of secondhand smoke exposure, especially in underserved communities. To guide South Carolina's tobacco control efforts, we need to first quantify the burden of secondhand smoke-related mortality specific to our state, public health regions, and our counties. And this is what leads us to our research contract. So we've been working with Helen and Sharon for a little over 3 years working on this project. So we were awarded a 3-year research contract in fall of 2021 to answer the question, what is the population and economic burden of death caused by secondhand smoke exposure in South Carolina? So we were able to complete most of our work by fall of last year. And so we're still revising and refining our econometrics calculations, so the economic burden side of things. And so we were able to develop several key deliverables, many of which I'll talk about today, but 2 of which are specific to the presentation today. And that is our population burden manuscript, where we're going to go over our estimated secondhand smoke caused deaths for coronary heart disease, lung cancer, and stroke among non-smokers. And the second was building off what we did from the first manuscript, and that was the policy analysis manuscript, where we're examining the correlations between smoke-free ordinances and our secondhand smoke caused mortality estimates. So Helen's on the call. We had to repackage our first manuscript. It was rejected from the journal that we submitted to initially, so we're going to be submitting this to Public Health Reports, but it's our state-specific estimation of deaths attributable to secondhand smoke exposure among non-smoking adults, insights from South Carolina. This is going to be an original research manuscript that we're going to submit in the coming weeks. And so just to walk you through our study, as we mentioned, secondhand smoke exposure is a causal source of coronary heart disease, lung cancer, and stroke. And using appropriate state-level data, state-specific population attributable risks, can be calculated to guide public health strategies to reduce population exposure to secondhand smoke. So our aim of our study was to estimate the population burden of mortality caused by secondhand smoke exposure among non-smoking adults in South Carolina. Now we're going to get into the methods a little bit. I have more slides. There's a lot of detail, but for the sake of time, I'm kind of giving the overview and trying to simplify. So we calculated population attributable risks for coronary heart disease, lung cancer, and stroke deaths in non-smokers due to secondhand smoke. So when I'm referring to population attributable risks, it's also referred to as population attributable fractions. And this method is used to estimate secondhand smoke attributable mortality. It calculates the proportion of deaths from a specific cause that can be attributed to secondhand smoke exposure. And so we use the same prevalence-based methods that the CDC uses for their smoking attributable mortality, morbidity, and economic costs, also referred to as their SAMEC calculations. And we further expanded on it by examining the secondhand smoker attributable mortality among non-smokers due to stroke. So SAMEC is one of the most widely used methods to determine smoking attributable mortality estimates in the literature. And so we were excited to utilize these methods and then utilize one of the changes that occurred in 2013. So there's a research team, Wendy Max and her team were able to improve the population burden estimates of death and revise the SAMET calculations according to their work. And I'm going to get into their calculations, which is what we based our work off of. And so the reason why we're focusing on these prevalence-based methods is because that was what the best available state data was for us, based on our state surveillance data of, adult tobacco use, exposure to secondhand smoke, as well as our mortality data. And that leads us to the two data sources, and that's the South Carolina Adult Tobacco Survey. So from this survey, we're able to estimate secondhand smoke exposure prevalence and adult smoking status. And then we needed our mortality data for each of our 3 outcomes, and that came from the South Carolina Community Assessment Network. And so we ended up combining the 2014 and 2017 South Carolina Adult Tobacco Surveys. We mean-centered the survey weights and calculated the weighted prevalence of non-smoking adults exposed to secondhand smoke in the home or workplace. And so it was essential for us to, combine the two methodologically, most similar study or surveillance data sets that we could, and that was the 2014, 2017 South Carolina Adult Tobacco Surveys. We were able to calculate the weighted prevalence of adults who are current or former smokers. And then we were able to get our South Carolina Community Assessment Network mortality data, and that was used as the overall number of deaths in South Carolina public health regions and counties. And so we took the average number of deaths for each of our 3 outcomes for 2014, 15, 17, and 18. And then we took the average number of deaths between the 14, 15, and 17, 18 periods. And so to give you an idea of some of the inputs and the calculations to help us better understand what exactly we did, there are 3 specific formulas that Max and her team used to calculate the number of secondhand smoke attributable deaths for heart disease and lung cancer. So in their study, they were just looking at these 2 outcomes, but they multiply the secondhand smoke attributable fraction for non-smokers by each condition's death total among non-smokers. And so hopefully with the formulas below, this will make a little bit more sense, and we're going to walk through the steps. Excuse me. So the secondhand smoke attributable fraction, or the SAF, SHS, in the first equation measures the proportion of deaths caused by secondhand smoke exposure among non-smokers, and it's calculated using the prevalence of secondhand smoke exposure, which is PSHS, and the increased risk of death for exposed non-smokers, which is the relative risk of secondhand smoke. Now, the relative risk inputs that we used were provided by the Office of Smoking and Health Personnel. We reached out to CDC, and Helen and Dan set up our meeting with their team, and we met up with Linda and her staff. And so they provided us with a lot of key information and resources and information. And so those inputs are at the end of the presentation if you're interested. The smoking attributable fraction for current smokers is equation 2. This measures the proportion of deaths caused by active smoking among all adults, and it uses the prevalence of current smokers, so PCS, former smokers, PFS, and never smokers, PNS, along with their respective risks of death. And so we need this fraction to multiply it by the total number of death in the next equation, which is our death among non-smokers. And so finally, the number of deaths among non-smokers, you get that by subtracting active smoking related deaths from the total number of deaths, and then you adjust it for the proportion of non-smokers in the population. So I know that's a lot going in. So you take your first equation, multiply it by the outcome of your second, and this gives you your number of secondhand smoke caused deaths for each of your outcomes. So when you do these types of calculations, your estimates may not sum neatly based on missing data from your surveillance data. So you might get an overall state total, and then as you start stratifying it by sex, race, ethnicity, and then age groups, obviously you're going to have, more and more missing data as you begin to stratify these data. So, we ended up rescaling it and adjusting our initial mortality estimates to sum neatly for the econometric side of things to our state totals, and then we age adjusted them to the 2000 US population standard to refine our crude mortality rates further. So that being said, let's get into the results. That's enough of the methods, and actually share what we found. So secondhand smoke caused deaths totaled 371 deaths per year with a crude death rate of 7.5 per 100,000 individuals. Men experienced a 74% higher death rate than women. Crude secondhand smoke caused death rates were similar for white and black adults, but when we age adjusted it, secondhand smoke caused death rates were 10.4% higher for black men and women compared to white men and women. And so I'm just giving you a small little taste of like the state data that we have. We have a lot more estimates, and I'll show you the county level here momentarily, but just to give you an idea. So here we have our county level estimates. So here you can see that there's greater than a 4.4-fold variation. So there's a wide variability from our lowest crude mortality rates, which are, that first quartile, which is 3.59 to 7.02, to our largest, quartile, which is the 10.9 to 15.9. And so counties with the lowest crude secondhand smoke cause mortality rates are going to be like more of your, I guess that's going to be your light beige. And these are the areas or the counties that had the lowest estimated secondhand smoke cause death rates. And they're doing better compared to other areas in the state when it comes to secondhand smoke related mortality. Whereas when you see more light green, teal, and especially the dark blue, these are the counties that the dark blue are the counties that had the highest secondhand smoke related death rates. And people living in these areas face the greatest health burden from secondhand smoke exposure. But this gives us at least an idea with this chloropleth map where, the population burden is more geospatially across the state and maybe areas to be able to, kind of focus different policy interventions. So this work really set up what we were to do then for our second manuscript, which, we're currently repackaging. We're holding out hope that we'll get, insight back from the journal editor, but we developed a GIS snapshot and it was in response to a call for papers for rural health disparities. And so our second paper was examining the geographical distribution of local smoke-free ordinance coverage and secondhand smoke attributable mortality across South Carolina. And so this paper was really to begin to examine, where all do we have statewide tobacco control policies at the local level? And I do want to, give a shout out. Helen was telling me that I think we're up to, is it 70 local smoke-free ordinances across South Carolina? I think that's right.
Yes, that's correct.
Woo, okay. So my mind hasn't failed me yet. We're getting fuzzy though. So South Carolina, in particular, we faced a lot of challenges, particularly in enacting statewide tobacco control policies. But, it's a testament to a lot of the people on this call for this roundtable discussion, to many others who have worked on this, subject before us, that there's been substantial progress made. So I just really want to recognize that work that's been put in. And so our study aimed to investigate the correlation between county level smoke-free ordinances and secondhand smoke attributable mortality rates. And so for our methods, I promise not to get as crazy as the last one. But we use data from the Census Bureau Cities and Towns Vintage 2014 South Carolina file. And the South Carolina Department of Public Health Smoke-Free Workplace Ordinances map were used to calculate the percentage of each county's population covered by smoke-free ordinances. And so the calculation accounted for the duration of enacted policies by dividing the number of days since each ordinance's enactment up to January 1st, 2014. The reason we did this was to make sure that this was a clear cutoff before any of the data collection for the South Carolina Adult Tobacco Survey. So we fully recognize that, the progression of disease development is going to take some time and there's a lag period for each of our three outcomes. So we just want to make sure there's a clear cut point before any of that data was collected for the 2014 Adult Tobacco Survey. And that's why we selected that cut point. And then we also, accounted for leap years. And so for counties with multiple smoke-free ordinances enacted before January 1st of 2014, an average yearly fraction was calculated to account for the overall policy duration. And so we ended up, none of our data was normally distributed, but we used Spearman rank correlations to analyze the association between the percentage of the population covered by smoke-free ordinances and the county level secondhand smoke mortality rates. And so here is the correlation matrix, with our findings that I wanted to share with you. And so I was going to walk us through column 1. And so just to give us a couple of examples, so from our first manuscript, we were really working on developing state and regional and then county level secondhand smoke cause mortality rate estimates, right? So you have the number of counties, your mean value, and your standard deviation. And so the mean here would be 8.9, so a crude mortality rate of 8.9 per 100,000 individuals. And so the ratio of the county of the population covered by local smoke-free ordinances is really going to be like the percentage of that particular county covered by smoke-free ordinances. So in this case, it would be 19.5% of that county's population on average is covered by smoke-free ordinances. It would be, the state average. So when we start looking at, the correlation with variable 1, which is our mortality rates, and then each of our different attributes of our smoke-free policy ordinances, you can see that there is a statistically significant inverse correlation with pretty much all of them, So that being said, your ratio is really kind of the main one I wanted to focus on at first, which is the counties with a larger proportion of their population covered by smoke-free laws tended to have lower secondhand smoke-related deaths. And so the other one was duration. So what this means by the yearly fraction is basically we were just looking to see the longer that smoke-free laws are in place, how does that then correlate to secondhand smoke-related deaths? And so we did observe that the longer the smoke-free laws are in place, the fewer secondhand smoke-related deaths that are observed. And so it's likely because of different benefits of the policies that accumulate over time. So this mean that you're seeing here is on average counties that had a smoke-free policy in place for about 1.5 years as of January 1st, 2014. Um, so that's what this means in relation to that crude mortality rate. So what does that look like, with two choropleth maps and geospatially? How can we look at this in a more simplified way to better understand these patterns? And I think this visually does a pretty good job. We have two maps here. Map A is looking at your county level smoke-free policy coverage, which ranged from no coverage, 0% in 26 counties, to 100% in only one county of the population covered by smoke-free ordinances. And then map B is your county level secondhand smoke cause mortality rates. And then we have this in 3 equal groups for our categories here. And so you can begin to see some patterns emerging in terms of the darker pink highlights the higher the population coverage is versus, the dark blue is, the counties with the higher population burden of secondhand smoke caused deaths. So the lighter the better, the darker the worse. So you can start to see darker pink emerging where there's lighter blue. And when you put this together, here we have a bivariate choropleth map. So if you wanted to look at two continuous values, superimpose and put them together, that's what you have here for map C. So this tends to show that this inverse correlation between secondhand smoke caused mortality rates and smoke-free policy coverage, and counties with a higher percentage of the population protected by smoke-free ordinances generally had lower mortality rates. And I think that this visual impression reinforces, what we found with our Spearman rank correlations based on the data from table 1. And so you can see that counties with longer well, you can't really see this one, but it's really the first bullet. So I just wanted to make sure I wasn't too confusing here. But counties with that higher percentage did in fact show lower secondhand smoke attributable crude mortality rates. And so we were just really excited because when you can start to see patterns emerging here, we don't have many patterns in the middle. So this inverse correlation you start to see in terms of increased policy coverage and increased mortality, that you see kind of this pattern here and this pattern here. So with that, I do want to conclude and bring us to some points of action here as I wrap up. So we did identify that secondhand smoke exposure in South Carolina leads to, 371 annual deaths. That's like losing 2 Boeing 737s of passengers in South Carolina every year due to something that's completely preventable. It's a diverse, it's a diverse impact and influence. It impacts various demographics, regions, and it's a very broad-reaching issue. And we know that advocacy is essential, especially in trying to protect residential spaces, and public education is crucial to supporting smoke-free initiatives. Moreover, increasing the population coverage by smoke-free ordinances is correlated with lower secondhand smoke mortality rates, warranting further expansion of local smoke-free protections. I do want to say the correlations here do suggest, we do have that association between our policy coverage and our mortality, and this is a good foundation for us to then build upon these calculations for future research, but also just giving us, starting point for our advocates as well. So, we've made a lot of progress, as we mentioned, with 70, local smoke-free ordinances in place. We still have more work to be done, and there are going to be challenges such as time, effort, trying to gain support from elected officials, but overcoming these obstacles can save lives. The steps that you can take are partnering, if you haven't already, with South Carolina's Department of Public Health Tobacco Prevention and Control section. I'm going to give a shout out to Helen to promote tobacco-free initiatives across schools, faith-based settings, healthcare facilities, and work sites. They have amazing resources on their website for different tobacco-free policies and frameworks and best practices. So you can share the public health benefits of tobacco-free policies with community leaders, school administrators, government officials, model tobacco-free policies and tools to help organizations and institutions really kind of really strengthen and really develop more comprehensive policies based on their needs. And so if we all collectively advocate for comprehensive, equitable, smoke-free policies that ensures clean, smoke-free air for everyone, it's essential for us to advocate that way to safeguard public health and protect everyone from the harms of secondhand smoke. So with that, I think I'm right at 22 minutes. So I have extra slides and I have time for questions. Hopefully I didn't get too technical with the details, but thank you all for having me.
Thank
I
you.
see a hand. Oh yeah, sorry. It's all you, Tara.
I was just saying thanks, but I do see where Dr. Keeley has his hand up. So go ahead, Dr. Keeley.
Yeah, hey, great. That's a very impressive body of work. Thank you for sharing. And my question really, I was, well, one comment. I was so glad to see that you pulled in the geography piece, where you kind of overlaid where the higher mortality risks were with where the smoke-free policies were. That's really great. My question really was back to methods. You mentioned weighting, that you did weighting. I was wondering what you could just tell us what kind of weighting, you decisions you came to, and just maybe explain that a little bit.
Yeah, so it was really, and that's a great question. So it was really making sure that we were utilizing the sampling weights correctly instead of just using frequencies in our calculations. When we, needed to calculate the weighted prevalence, that gives us more of an accurate picture of, you know, sampling from our overall population in South Carolina. So when you properly specify in like our coding that you are getting weighted frequencies versus just normal frequencies, the weighted frequencies give you the representative sample, so to speak, of your target population within your sample. So it gives you a better estimate of
Mhm.
basically the population demographics that you sampled from based on the sampling methods that you at least the sampling weights that you were implementing. So we just were making sure that we were consistent with that, and we wanted to make sure
Yeah.
that that would give us a solid starting point.
Okay. Yeah, I understand sampling and but every once in a while I hear out we had to oversample a certain demographic group because, of the way that the survey, was responses came in, we needed to do some oversampling or weighting, and so I understand that. It's just, and it sounds like you wanted to be with the survey data that you were using, you wanted to be consistent with those weights. Is that basically what you just said, right?
Right. And
Yeah.
the reason we also were able to combine the 2014 and 2017 was methodologically they had the same methods, so we could combine those. And I didn't get a chance to like share table one and other things just based on time, but it was over 14,000 individuals that were sampled. And then when you apply those weights, so the weighted prevalence of secondhand smoke, which was tracking with national estimates, was around 16.5% of non-smokers who were exposed to secondhand smoke, which was very similar to around that 20% mark. It was a little bit under. So with that being said, we were, tracking our weighted calculations with what the national estimates were, and we felt pretty good with where those were. And but you're right. There are a lot of assumptions you have to make and a lot of inputs, which is why I wanted to spend time on kind of the equations, because you have multiple sets of relative risks. I was mentioning the ones from the Office of Smoking and Health. We also had relative risks that we need to pull in from the, peer-reviewed scientific literature in terms of, what's the relative risk of death for current and former smokers developing lung cancer, coronary heart disease, and stroke. And so those were also inputs we needed to put into those equations as well. So yeah, there are lots of parts and pieces, but we wanted to make sure, if we apply the proper sampling weights, then we felt good about the foundation that would set for future
The
pieces of
calculations.
that calculation.
Yeah.
Yeah.
I see Dr. Morgan's got her hand up. I see.
Hey, how
Hi,
are you, Dr. Morgan?
thank you. Hi, wonderful presentation. Thank you so much on behalf of all the data geeks that exist out there.
You're
But
welcome. Thank you.
my question, and I'm sorry if this seems like a silly question. How do we know that a death is deemed due to secondhand smoke?
That's not a dumb question. So yeah, it goes back to that population attributable risk approach. And so we're trying to basically, let me go all the way back up here. I'm sorry. Because I know I was moving quickly and I apologize. But yeah, I just wanted to make sure that I could share it and make sure it made as much sense as possible. Okay, so when we're estimating secondhand smoke, or if it's death due to smoking for specific causes of disease, so the population attributable fraction method calculates that proportion of deaths from a specific cause that can be attributed to secondhand smoke exposure. So what Wendy and her team did when you're looking at these calculations, so what they wanted to do was remove the number of deaths that theoretically could have happened from current smoking or other outcomes, which is part of the reason why we feel good about the methodology that Wendy and her team did, because this was actually incorporated into the CDC's methodology back in 2013, because it refined their ability to just look at secondhand smoke specifically. And so when you're looking at those prevalence-based methods, you're really just looking at secondhand smoke exposure, and then you're ruling out other causes from like current smoking that also go into it. So does it help to look at, I guess, the equations a little bit in terms of, just trying to rule out other potential causes? Because that's kind of like, I could send you more information that would better answer your question, about like the path and population attributable risk method. Because I feel bad. I feel like I'm not doing a good job. I'm going to blame baby brain this morning. I'm sorry. But it's really to just try and rule out other causes and look at just specifically the prevalence of secondhand smoke exposure among non-smokers. So when you obtain kind of what that SAF for secondhand smoke is, and then you take it, and since you've ruled out other causes and you multiply it by the death among non-smokers, that's essentially how you're trying to get just as close as you can a best estimate of the number of deaths that are occurring from that single factor, if you can.
Gotcha, thank you.
Hopefully that helps. I'm sorry, Dr. Morgan.
It does, it helps.
I think it's like a process of elimination, because you're looking at the deaths and then you're trying to eliminate the other reasons and then doing the calculations by the rate of deaths, which must probably the most simplistic, boiled down definition.
Right. And
Yeah.
I appreciate that, because yeah, it's I know it's gonna be more intuitive if depending on how you want to look at it. I know like as a visual learner, I needed to like see it multiple times before I was like looking at it and doing it. But I could also do a better job explaining. So that's something I can do better, moving forward here. But you're right. So it's just trying to, really account for other causes and just really nail down as specifically as you can to secondhand smoke exposure. Yeah. I think
Vanessa
two
and Dr.
hands.
Keeley. Yeah. Vanessa, you want to go?
Yeah, absolutely. Reston, thank you so much. This was a conglomerate of information. It's great information to know. Thank you for sharing. One thing I had a question about, well, several things, but just one right now. When it has the call to action, the progress and challenges, one of them you stated was time. Is that time geared toward the commitment of those like stakeholders or those that are participating in it, or time to do additional study? What was that? What was that
Great
time?
question. So it could apply to all the above. So I know with the specific call to action here, it can take time to build relationships. It can take time
Mhm.
to, understand. And I know Beth and Helen, you guys can talk to different aspects of this. Dr. Keeley, you could too. Whether it's building that relationship with your elected official, learning kind of what their priorities are, what they're excited to do in terms of tobacco prevention and control, and just kind of seeing kind of what your leverages are kind of based on your relationship with them. Like how far can we move forward different initiatives and build support for that? When it comes to just the policy change process, it is very slow. And so it can take a lot of time and energy and effort, especially to, at the grassroots level, keep a lot of people engaged over long periods of time to keep them excited about, a legislative change. You get that legislative victory, but if it's, 2 to 3 years down the road, maybe longer, and that's where I'll defer to other expertise, on the call. But that was partly what I was referring to there, was some of that time and energy is just knowing that you're kind of in it for the long haul. It's the long game. So you really have to be committed to just being excited about incremental victories along the way, because it's not going to be done overnight, but it's just understanding, okay, so it took us 3 years to be able to get population burden estimates just to understand, how many secondhand smoke caused deaths reasonably can we estimate for secondhand smoke exposures at home or workplace among non-smokers in South Carolina. And we're still working on the cost of what these deaths actually cost our healthcare system. So we're almost to that point. But yeah, so I'll let others speak to kind of some of that time, but does that help a little bit as far as?
Absolutely, absolutely. Thank you for sharing that, Reston. Reston, thank you so much. I'm certain that included, say, creating focus groups and things like that. So,
Right.
yeah. Okay, yes, thank you so much. Yes, it answers the question. Thank you.
You're welcome.
Dr. Keeley?
Yeah. I'm thinking about mortality, and with your mapping, I think SIDS has secondhand tobacco smoke exposure somehow as a risk factor. I was wondering whether your team is thinking about doing any other kind of look in South Carolina at numbers and where there's is and where there aren't indoor smoke-free policies.
That's a great question. We did not look at SID specifically,
Yeah.
but I could, reach out to Dr. Alberg and see what, what he thinks. But yeah, we didn't. We were just focusing on the three, outcomes that we knew have been causally linked with secondhand smoke exposure. And so
Yeah.
we just were keeping it to adults. But no, that's a good point. It's worth, future investigation.
Yeah, just a thought. I will tell Vanessa that, when we did the policy work in Rock Hill, we had to look at where the pushback was going to come. And at that time, it was a lot of restaurant and bar owners. And so we ended up having meetings or sharing key information with the Hospitality Association, and that really helped. And then one thing that you can quote, we looked at, instead of mortality, we looked at acute MI admissions to emergency departments. We had one main hospital in York County, and then we had to get data from Charlotte hospitals. But we were able to track the 3 years of acute emergency room admissions for acute MI, 2007, 8, and 9, or 6, 7, and 8, and then we did 2009, 10, and 11, and we showed a 20% decrease in admissions for emergent heart attack admissions to our the emergency rooms where people would get admitted, and that really caught the attention of county and city leaders, and so they really got behind the the enforcement. That's one thing. You get an ordinance, and you still have to deal with how compliant people are to the new ordinance. So those are just two things to mention. With the grassroots education that can be looking at going forward.
Dr. Kelly, thank you for sharing that information. And just for my observation over the last couple of weeks, the greatest amount of smokers I have seen, I don't know if it's surprising or not surprising, has been the grounds of a hospital. I've seen a lot of smokers on the property outdoors of a hospital.
Yeah. Well, that's an area where
Mhm.
in York County we had that. We had a smoking station outside the door, main entrance areas.
Mhm.
And then finally the hospital said, this is not going to work. So they just said you have to either be in your car or
Mhm.
off campus. So for a while, we had people walking the block to get across the street and
Mhm.
smoke. Yeah.
Absolutely.
Yeah.
So Rustin, my question would be, can we use this data? I mean, is it out
Okay.
there for us to be able to to use in our fight for smoke-free laws? Oh, you're on mute, babe.
I thought I got used to this. I'm not good at this anymore. Okay. So I
You're
would
great.
say you can definitely use this data when the thing that we're still waiting to finalize, and Helen, I'll defer to you as far as how y'all, because I know it's basically more up to Helen, I think, than anything. So as far as what's still being finalized. So it's the actual economic burden calculations. So we're also collaborating with Mahmoud Khan and Ibrahim Demir at the University of Georgia at the College of Public Health there. And so they've been working on that side for us. And so we're still finalizing the report based on the econometrics piece of it. So to actually get a sense of what this costs, and the initial preliminary findings are quite high. So we're excited to see where that work is taking us. But as far as the population burden side goes, you can definitely probably use that, and it's more readily available than the econometrics piece of that. Because the reason why I wanted to just say, like, here's some deliverables that you might want to keep your eyes on as far as what you can potentially share, because I know infographics are helpful if you want to potentially share those with community members and just help them kind of digest this a little bit more, because I know it's technically heavy, but this is something that I'll get your feedback and comments here to see what you think as well. But we're working to finalize this as quickly as we can.
Absolutely. We want to. That's a great question, Barbara, because it's not good enough just to have the research project. What do we want to do with it? We certainly want to apply it as an advocacy tool, an education tool for those folks who are trying to promote smoke-free ordinances. What we'd like to do first, though, is to get the burden report completed, and then we will put out the infographics and the synopsis, the talking points through DPH. So it's not quite ready yet, but it will be soon. And then we'll supply that to all the partners, because we want it to be used comprehensively in the same formatting and such. So yes, just give us a little bit of time so that we can get this completed, and then yes, get it out to everybody to start using.
Great.
So
And
not yet.
Thank you, Helen. I just wanted to make sure I had that because I didn't want to overstep there. So my apologies.
yeah.
No
Thanks,
problem.
Helen. That's great. We'll keep bugging you. And Rustin, these infographics that you have up now, are they readily available to us? Are
So
these
Helen's
on
going to make
y'all's?
those readily available as well.
Yeah, those are going to be on hold a little bit. These are great. I think what we might do is simplify them just a little bit for community use. So just give us a little bit of time, and then we'll get these out. But yes, we certainly want people to use them, but it's not ready for use yet. So this is internal only for the partners, so that you would be aware of the study, you would be aware of the methods, you'd be aware of the fact that, it has been done. And, but the tools, the communication tools are not ready yet.
But we're close. Yeah, that's kind of I'm glad that question was asked. So thank you, Barbara. That was a good one, because you're right. I mean, because there's a lot more in the report that you're going to find. No, Dr. Morgan, I see your hand there too. So yeah, there's quite a bit more in terms of the data, the estimates. We didn't get into the bounded estimates from more conservative to the least conservative, just to provide us with a range of what these estimates look like based on exposure. So there's a lot to look forward to down the pike. So yes, Dr. Morgan.
Yeah, I just want to ask when DPH, I'm sorry, I have to get used to saying it. When DPH is ready, I think it would be great, hint hint, if y'all can blow up the infographic with the counties and the colors about mortality and how it relates to policy. Like, I think that could be an excellent teaching tool, like when we're going and speaking to decision makers and educating them about health implications.
Absolutely. We love the fact that Reston had broken it down, overall state, and then he'd broken it down by county, but then he also crossed over and broke it down by public health region. So that was important to have all those cross layer pieces. And then what we can do is we can show it with an overlay, hopefully, of where the smoke-free ordinances are and where they're not, because that's the story. The bottom line is the number of deaths, but it's also showing it's indicative of smoke-free ordinances, provide and protect people, and that they have better health, and less death due to stroke and cancer because these ordinances are in place. So absolutely, LaShondra, yeah, that's in the plans.
Yeah, this slide is very powerful, and I really think that once the decision makers see this information, they're going to have to be accountable. So yeah, this is powerful.
Thank you. We certainly hope so. We were kind of blown away by just all of the information. And I know Reston has mentioned, and I have as well, but Reston, do you just want to say just a couple of little quick blurbs about the economic burden, like what they're trying to capture, and just a tiny, maybe a teaser, because I think as soon as that is really completed, that should be the next presentation to all the partners, because the burden information is overwhelming. It will just completely blow your mind.
I was going to pull up just a couple of the slides from post year one. And so just to give you an idea. So 1 second, let me grab those real quick.
I was squinting and reading some of the economic numbers on the infographics, and they are definitely eye-catching.
They're quite, yeah, it's remarkable, just the potential costs. So the reason why, as I'm loading this real quick, part of the reason why it's been such a challenge to get that kind of refined a little bit more is mainly because ICD codes and, discharge data and, the healthcare data records, there are a lot of duplicative, there are a lot of duplicates that they're trying to work through, and not, I mean, with some of that, they're trying not to double count certain costs as they're going through it. So we're hopefully going to be meeting here in the next couple of weeks to kind of go through and try to work through some of the data cleaning issues that I know Dr. Khan and Ibrahim have been working on, but they've been really good to give us some really good information. And so I just need to find, here we are. Sorry, 1 second. I can't speak as much to the equations that they used, but they were considering direct medical care costs per year, value of life years lost due to secondhand smoke. I can show you some of the equations briefly, but they were looking at potentially the average prevalence, the annual cost per case. They used our secondhand smoke retrieval fraction and to be able to estimate the estimated healthcare expenditures. So I'll briefly pull that up real quick. Because we were hoping to potentially get Ibrahim on, but I think he'll probably be able to join at a later date. So again, I'm not going to be able to speak to their equations and all that goes into the calculations, but I will go ahead and share just the estimate of medical care expenditures. So the estimated healthcare expenditures for lung cancer, heart disease, and stroke, I mean, you can start to see how quickly these costs add up for something that is a preventable cause of death. And for almost, what is that, 100 million. So it's quite remarkable when you look at some of these estimates, as well as when you factor in, the value of life years on top of it. And so this is probably the one I would share, Helen, since they're still working on the other preliminary results, but this
Okay.
was probably where I'll leave it. But just to give you an idea of the total economic loss. So we're still working on this side of the project in this study. But just to get an idea of the direct medical care costs associated with secondhand smoke, in 2023 prices and the economic value of years of life lost. So, when you have almost $500 million in costs due to secondhand smoke exposure, it's quite remarkable.
And that's annually.
Correct.
Hey, Reston, is there any way they can look at whether what percentage of these costs were covered by private insurance, and what covered by Medicaid, and what was covered where there was self-pay?
I'm going to write that question down and ask them, Dr. Keeley.
Because
That's a
that'll
great
get the
question.
attention, of decision makers.
And that's an important one to to ask. I think, because I was trying to remember, since I haven't seen their breakdown of like, kind of their descriptive table of how they were like breaking down the costs by like records. And, I'm not sure, depending on what pay source they're
Yeah,
looking at, but they might, have that information already ready to go. I don't know, but I can ask them
yeah.
and clarify. So they'll bring that up, but that would be very meaningful and very powerful.
Definitely.
So this is the start. So there's more good to come. We're learning more about this issue. It started with the population burden side of things from more of a descriptive study, because you don't know what you don't know. So, I mean, based on just the prevalence of secondhand smoke exposure, it gives us a good sense of what are reasonable mortality estimates that are tracking with national estimates. And, we didn't have anything at the state, region, or county levels. So we have novel estimates for the first time to be able to understand what that population burden looks like. On top of it, we're trying to better understand the comparability by creating crude mortality rates, refining that further, age adjusting it, looking at the econometrics piece of it. And this will set the foundation for more analytical work and, more hypothesis testing down the road. So that's really kind of, it's creating a firm foundation. And so I know this 3-year process has, it seems like a long time, but we've got a lot of parts and pieces in the works to provide a better understanding of our, the best way to approach different tobacco control initiatives, especially how we can, better protect South Carolinians from secondhand smoke exposure. So I'm excited to see where the project goes. And, I know Helen's been really sweet and patient to put up with us. And so trying to figure out, there are a lot of moving parts and pieces, but just so that there's a lot, going into it, and we're excited to be able to see where it's going to go.
It's super exciting because we've never had these results, this information for the state, something that I've been asking for. The project's been worked on for the last 3 years, but I had been asking for this information for the last 10 years. And we were just really fortunate to be able to work with USC, Reston, and Dr. Alberg and their team, because we had always had this information, or had it in the last 10, 15 years for smoking, for those who smoke, but we've never had the information for the secondhand smoke exposure piece. And we needed that to show the correlation between the ordinances and the protections. So we're really looking forward to using the results and getting it out to everybody. So it's just, again, another education and advocacy tool for those local advocates to show to decision makers. And like you said, LaShondra, and I think Vanessa and a couple other folks, it's very telling. And hopefully these decision makers just can't ignore this evidence.
Well, thank you so much, everybody. Reston, thank you. It's a great presentation. And we've had a lot of questions, and just a lot of excitement about seeing this data. So thank you so much for bringing it. Helen, thank you so much for working with him on this and also bringing it to our attention and getting Reston on our calendar. Reston, you have an open invitation. Whenever you want to come back and share more, please just let us know, or we want to hear it. So thank you again so much. Next month, we're going to have, well, Tara, I'm going to let you tell them who we're going to have next month. It's Suzette is going to come from DPH.
Yeah, so we're continuing our region, our DPH region updates. Suzette McClellan from the PD region will be presenting on the work they've been doing involving tobacco prevention and control. And then in March, we're excited to have Dr. Brian King from the FDA Center for Tobacco Products. Will be leading our roundtable in March. He's so busy. We've been working with his office for months trying to pinpoint when he can come, and we're excited about March. So I'll, as always, you know, our roundtable information is on our e-newsletter, so make sure you've signed up for that. And then it's also on our website under the roundtable tab, and that's how you register as well. So
And we're going to be
excited.
Oh, sorry, Tara, I thought you were done.
I am.
I was just going to say, we're going to send out an email to our users, to our partners, asking for questions for Dr. King. He likes to see them in advance. And so when we send that out, please send us your questions so we can forward it to him and he can answer them in either his presentation or in a question and answer seminar. Okay.
And Reston, when I know you said you're going through the peer review process right now, but whenever y'all get that finalized, let us know and we can link the article in our newsletter as well.
Yeah.
Oh, that'd be great. Yeah, I'll definitely keep you guys posted. And if you have any questions or if anyone has any additional questions, I'd be happy to, go into more detail, and you can get my contact information. I can either put it in the chat or you can get it through Marpa or Tara. So, but yeah, I'll be happy to do that.
Thank you so much, everybody.
Hey, one quick thing,
Oh.
Reston, make sure that you share this with A&R in the foundation. Their focus is on secondhand smoke, and so they'll probably help you get your final report out there if you let A&R know. It's Americans for Non-Smokers' Rights Foundation. Yeah.
Thank you. That's a good point.
Helen probably knows that, but thought I'd mention it. Yeah.
And we can certainly get you in contact with the South Carolina contact who's on Jewel. So we
Okay.
can definitely link you up with her. Yeah.
Thank you.
All right.
All
I
right.
appreciate it. Thank you.
Outstanding. Yeah. Thank you all.
All right, everybody. I think that's it. Gonna close it out, and everybody have a great weekend. Happy Friday.
So good seeing you all. Hope you have a great weekend.
Thank you. Same to you.
Bye-bye.
Thanks.